अभी मैम आप डॉक्टर सीमा ग्रोवर को भी इन ले लीजिए।
ओके
ओके।
problem, then it is the most frequent.
Avi ma'am, Seema ma'am and Nishit sir are there?
yes
Okay. Okay. Just to inform you, sir and ma'am, that Dr. Dhananjay won't be there. He's busy somewhere. So we'll continue with the old format. Okay, we're live. So I'll share the link to all the other groups. Okay.
Hello? CP?
Avi ma'am, we have Avi ma'am, do we have enough participants? Shall we start?
Yes, I think we shall start. Yes. We have, I think,
Okay.
99 participants
Okay.
on
Okay.
Zoom and rest on YouTube Live.
Okay. Okay. Okay, ma'am. Okay. Nidhi ma'am is here.
Yeah. Acha.
Okay, ma'am. A very warm morning to one and all present here. I am Dr. Shaheen Khanam, Assistant Professor at BCIP, Banarsi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP, I would now like to invite Dr. Nidhi Kalra, Associating in Charge, to please come and address the delegates and the participants and the guests. Thank you, ma'am.
Thank you, Shaheen ma'am. Well, on the behalf of BCIP family, the BCIP fraternity, I would like to welcome my guest resource person today, Dr. Nishit and Seema ma'am. And thank you all the delegates across country, and I can see here a few from abroad as well participating in this webinar. Thank you so much for showing this great interest in this webinar. Well, this is a very important and relevant topic since we all know that osteoarthritis, which is one of the commonest problems of the joint, and the prevalence is around 22 to 39% in India itself, which is quite high as a prevalence rate. So for this, if we can find different techniques, and if we are regularly bringing up newer techniques to regenerate the cartilage or help such patients, help the patients overcome their joint pain, I think this is the best part that we can do. And I am very happy that today we have organized the webinar on a technique which is cartilage regeneration technique, which is being practiced at Apollo. And we are going to cover the rehab part also by our legendary Seema ma'am, who has always been supportive. So thank you so much, Dr. Nishit and Dr. Seema. Thank you for coming and joining here today. And I hope all the delegates watching us on YouTube, as well as who have joined here on the Zoom meeting, would enjoy the webinar to the fullest. And I wish all of you to have a happy learning. And of course, BCIP would continue with this legacy of organizing different kind of very knowledgeable webinars with different faculty members, with different resource persons across the country. And I hope you stay in touch with us. Thank you so much. And I again welcome you all on this webinar. Thank you, Shaheen. Thank you.
Thank you so much, ma'am. Now I would like to officially ask the student, the host student, the student of literary and social media club to take over the charge. Over to you, Diksha.
Thank you, ma'am. Welcome, everyone. Rightly said, never stop learning because life never stops teaching. BCIP is here again with another webinar to update our knowledge in advancing technology in the field of orthopedics. A very good afternoon to one and all. I, Diksha, a BPT final year student, on behalf of the whole BCIP family, welcome our eminent speakers for today, Dr. Nishit Bhatnagar and Dr. Seema Grover. I would also like to extend a warm welcome to all our dignitaries, participants, teachers, and fellow students. Participants are requested to drop their queries in the chat box on Zoom or live chat on YouTube. We will be taking up the questions at the end of the session. To begin with, I would like to introduce our first speaker, Dr. Nishit Bhatnagar. Dr. Nishit Bhatnagar is a consultant orthopedic and joint replacement surgeon at Indraprasth Apollo Hospital, New Delhi, and he's also running his practice at the Restore Bone and Joint Clinic in Alaknanda, Sama Hospital, and Sanjeevan Hospital. So graduated as an MBBS gold medalist from the University College of Medical Sciences and did his MS Orthopedics from Maulana Azad Medical College, New Delhi. Sir also has several fellowships in joint replacement, computer-assisted surgery, sports injury, and arthroscopy from Germany. Dr. Bhatnagar is the youngest surgeon to perform arthroscopic cartilage transfer at Apollo Hospital and the youngest surgeon to perform partial knee replacement at Sama Hospital. Sir has more than 20 research publications in renowned national and international journals and 10 plus years of clinical experience and working with many prestigious hospitals. Sir will be sharing his profound knowledge on the topic cartilage regeneration techniques for cartilage defects. A very warm welcome, sir. Over to you.
Thank you, Deeksha, and thank you to the host, Dr. Shaheen, Dr. Nidhi, and all the hosts at BCIP for this wonderful opportunity to interact with so many uh, young people who are interested in this topic. Cartilage regeneration is something which is really coming up in the last, which has really come up in the last few years, and the reason for that is that total knee replacement and total hip replacement had actually established itself as a very successful surgery over the last 2 or 3 decades. But in spite of this, there were still 10 to 15% of patients who remained unsatisfied or dissatisfied after these sort of surgeries. That was probably because of the loss of proprioception or an artificial feeling that was possibly because of the artificial sensation that they got from the joints which had been put in. So lately, over the last decade or so, there has been a huge surge in research over cartilage regeneration and how we can preserve the joint. I had the good fortune of being in Germany as well as in Mumbai in some of the prestigious institutes where joint preservation surgery was being followed. And that is how my interest in cartilage regeneration techniques actually started. So let's begin this webinar and have a look at first, what are the causes of the cartilage defects? So most commonly, it can occur with an injury like a sports injury leading to an osteochondral fracture, where a piece of the bone as well as the cartilage has broken off. It can also result from osteochondritis dissecans, which is very commonly seen in young athletes or adolescent athletes, where a part of the bone just underlying the cartilage becomes avascular and has a tendency to break off along with the cartilage, leading to a defect in the joint. And of course, in osteoarthritis, where there is gradual wear and tear of the overlying cartilage. The problem with cartilage is that it does not heal quite as well as any other area of the body because the cartilage is avascular. So the regenerative potential of the cartilage is very poor. Even if it does regenerate, the fibrocartilage which is formed in place of the hyaline articular cartilage is usually not of the same quality as the original hyaline cartilage. And therefore, whenever there's a cartilage defect, some sort of intervention is necessary. So over a period of time, the cartilage defects and how they have been treated has evolved. And initially, very early on in the 1970s and 80s, we only had a surgical debridement or arthroscopic lavage that we could offer to the patient. And we have now come into 2020 where we can even offer patient therapies which are derived from stem cells. Overall, if we look at the management of any cartilage defect, we can broadly classify them into a conservative group of treatment or a surgical line of management. In the conservative group, usually those patients who have a very small cartilage defect or those young patients or children who have a very good regenerative potential are placed into the conservative group, and they are managed with braces and exercises. And Dr. Seema will definitely be covering some of these lines of management. It is the surgical group that I'll be focusing on more today. So in the surgical management of cartilage defect, we have 3 types of procedures. One type of procedure is a reparative procedure where we will go in and repair the cartilage, the original cartilage of the body itself. In the second type, we will either restore or use the cartilage from any other area of the body and put it in place of the defect. And the third is a palliative sort of treatment where only the pain and arthritis is being taken care of. So in the first type of surgical techniques, which is the reparative techniques, we either have reduction and fixation of the osteochondral fracture or fragment. This can be done either via arthroscopic means or via open means. That is making an incision, opening up the joint and fixing the cartilage piece which had broken off. The second type of reparative technique is drilling. Drilling can be done either through the joint or it can be done retroarticularly. We'll come to that in a short while. And the third type of technique, which is also similar to drilling, is a microfracture. So let's have a look at these reparative techniques in detail. So reduction and fixation is usually attempted for patients who have a very small lesion and which has not broken away completely from the original site. It is a fresh injury in a young patient who has good regenerative and good healing potential. And we can use 1 or 2 screws which have a very low profile head, which are also known as headless screws or Herbert screws, to fix this osteocartilaginous fragment. The second type of reparative procedure that we were talking about is a drilling. Drilling can be done in a transarticular or retroarticular manner. A transarticular manner is one in which arthroscopically we first look at the joint, identify the lesion, clear out the cartilage which was already necrotic, reach the raw subchondral bone. This is very important, reaching the raw subchondral bone. And then we use K-wire or small Kirschner wires and drill 3 to 5 millimeters or even up to 5 to 8 millimeters into the bone. And you will see that there is some blood which oozes out or fat droplets like this which ooze out, which indicates that this drilling has been adequate. These fat droplets and the blood which is streaming out has stem cells, and these stem cells will eventually adhere to the subchondral bone and create an overlying layer of fibrocartilage. This is a very easy and straightforward procedure, not very technically difficult. But the problem with this procedure sometimes is that these holes never fill up. And therefore, whatever cartilage was overlying, you have already removed it and you have created additional holes, leading to a problem later on in life. So a second type of drilling was introduced, which is known as the retroarticular drilling. In this, we do not drill through the joint, but we actually drill from behind through the bone. So this also starts in this manner, that we do a diagnostic arthroscopy, identify the defect, clear the debrided cartilage, and then we use a C-arm and localize where the particular osteochondral defect was and make the K-wire reach right up to the subchondral bone. Sometimes we can even place multiple K-wires, even up to 8 to 10 K-wires into that particular defect. An additional thing that can be done here is that the K-wire track which has been made, that can be further supplemented by bone marrow, which has been taken from the iliac crest to help and initiate the healing. The advantage of this particular technique is that the cartilage has not been pierced and the joint has not been pierced. But as you can see, it is technically more demanding because you're doing an arthroscopy as well as you're doing an open surgery and using a C-arm. And it's not always easy to reach these lesions via open surgery. The third type of reparative technique that we do is a microfracture. Microfracture is something which is similar to drilling, except that we don't use a K-wire in this. We have a microfracture awl, which comes in different sizes and different angles. And we can just hammer the tip of this awl into the bone and create holes into the subchondral bone as we had done with drilling. And this again initiates healing by the use of, by allowing stem cells to come into the defect. However, there are some techniques which are even superior to these. The reparative techniques will eventually lead to formation of a fibrocartilage over the defect, which is not of the same quality. We want hyaline articular cartilage over the defect. So for these, we have some restorative techniques. In the restorative techniques, we have OATS, which is osteochondral autograft transfer system, mosaicplasty, and autologous chondrocyte implantation, which is the actual stem cell therapy, which we will come to. So OATS, which is osteochondral autograft transfer. In this, we use a bone cartilage plug from the patient's own body or own joint and take it out from a particular area which is not very important in the knee and place it in that particular defect. Let's look at this example. This is my own video. So this was a patient, a young male, who had a hypercoagulable disorder. He had bilateral avascular necrosis of the hip as well as the osteochondritis of the femoral condyle. So this is the cartilage which is worn out and the subchondral bone which has become a little depressed here. And it was right on the weight bearing area. So what we did was, from a non-weight bearing area, we took a piece of cartilage and bone with the use of this harvester. So we will just place this harvester on an area which is not very important in the joint. We inserted it up to 1.5 centimeters and we took out a piece of bone and cartilage which was matching to the size of the original defect. So this is the cartilage which is coming out, and this is the defect which is left behind, but it is in a non-weight bearing area. And now the osteochondritis defect itself is removed to match the size of the plug that we have taken out. So you can see that we took out a 15 millimeter bone plug, and we have now taken out 13 millimeters of the osteochondritis lesion here. And now we will introduce the bone plug that we have harvested from a non-weight bearing area and tap it gently into the osteochondritis defect. So this is the bone plug that we harvested, which is going in. This is the cartilage surface, and it has gone right into the bed, and it is stabbed into the joint. So you can see the type of cartilage which has been placed in the defect is now absolutely good quality hyaline articular cartilage. This sort of cartilage you cannot ever get in a reparative sort of technique with microfractures or with drilling. This procedure can be done in an arthroscopic or in an open technique also. And when you do it in an open technique, it is called mosaic plasty. So if it's a small defect, you can use oats. But if it's a very large defect and you need to use multiple bone plugs, you can see that these bone plugs have been taken from areas of the knee which are not really weight bearing and do not come in contact with the patella also. And these have then been placed to fill the defect which was actually in the weight bearing area. This particular technique is known as mosaic plasty. But the most interesting of the techniques to regenerate cartilage is known as the autologous chondrocyte implantation. This is an actual stem cell technique, and this is done in 2 stages. So in the first stage surgery, we pick up pieces of cartilage or pick up pieces of bone marrow and from the patient himself, and we send those pieces to the lab where they are cultured, where a tissue culture is done over a period of around 4 to 6 weeks. Those stem cells are cultured and chondrocytes are prepared. And then in the second stage surgery, these chondrocytes are implanted back into the defect, and they are closed with a periosteal graft or with some artificial matrix. So again, stage 1 of this procedure is stem cell harvest. The stem cells can be taken either arthroscopically from the bone cartilage margin, or they can be taken from the bone marrow, that is the iliac crest, or lately we have also started doing liposuction and taking stem cells from the abdominal fat. These are in the stage 2, these are then sent to the lab for culture, and in the culture we isolate chondrocytes, which is what we want. And these chondrocytes are then over a period of 6 to 8 weeks, they are multiplied to grow into an adequate number and then sent back to the surgeon. And then via an open surgery, we can put these back. So let's have a look at this the last stage of this procedure where we are implanting the stem cells. So this is the defect. This is the cartilage defect, which is going to be taken out. The first step of any of these surgeries is that the dirty, necrotic, diseased cartilage has to be removed, and subchondral bone a bed of subchondral bone has to be exposed, because the subchondral bone has a good vascular supply, and that is what is going to initiate healing. This is a matrix, which is, so you can either put the stem cells and suture periosteum over it so that the stem cells do not go here and there and remain in the defect, or you have these artificial structures or artificial membranes. This is an artificial matrix membrane. Here we are putting the stem cells onto the defect, and this artificial membrane is now going to be placed over this defect so that the stem cells remain in its place. And you can see the membrane has been now put on and the paper is just being peeled off. Some people also suture this membrane or suture a periosteal layer over this so that the stem cells remain in this place. We are using the stem cells as a glue itself. And you can see it's stable even on moving. The membrane is not moving anywhere. And this heals over a period of time, again giving a good hyaline articular cartilage over the defect. So I think cartilage regeneration has come a long way over the last decade or so, and we are seeing more and more patients also coming in and inquiring about these sort of procedures where the native joint is preserved. And over the coming 10 to 15 years, cartilage regeneration techniques are really going to go into a boom. We are seeing more and more athletes coming in who want cartilage regeneration so that they are able to maintain an active and healthy lifestyle. And over the period of next 10 to 15 years, this is going to be the new thing to do. And it's not going away anywhere soon. Stem cells are here to stay, and they are the future. I thank the host for this wonderful opportunity to speak at this forum and have so many participants listen to this. Any questions are welcome. And now I'll hand over the presentation back to the host.
Thank you so much, sir. Diksha, you're there?
Thank you, sir, for sharing such valuable information regarding the surgical management of cartilage defects. Moving on to the final segment for today, we have with us Dr. Seema Grover. Dr. Seema Grover is presently working as Chief of Physiotherapy and Rehabilitation at Indraprasth Apollo Hospitals, New Delhi. She is practicing clinical physiotherapy for the last 29 years in tertiary care hospitals. She completed her master's in physiotherapy in orthopedics and is the first certified lymphedema therapist in India from the USA. She is having vast experience in treating primary and secondary lymphedema patients. Her key areas of interest are oncophysiotherapy, transplant rehabilitation, orthopedics, neurology, and geriatrics. She is the recipient of various prestigious awards such as the Lifetime Achievement, Best Clinician, Clinical Excellence, Significant Contribution in the Clinical category, and Lifetime Contribution to the field of physiotherapy. Apart from being a clinician, she is an advisory member of physiotherapy to the Board of Studies for various universities in Delhi and NCR. Presently, she is the Joint Secretary at the Delhi branch of the Indian Association of Physiotherapists. Ma'am will be sharing her profound knowledge on the topic physiotherapeutic management of cartilage regeneration techniques for cartilage defects. A very warm welcome, ma'am. Over to you.
Thank you so much, Diksha. And at the outset, I thank BCIP and Dr. Nidhi, Dr. Shaheen, and of course, Dr. Nishit to set the platform for so that I can take it for the very new technique for physiotherapists. So just to have the baseline before we talk about the rehabilitation or physiotherapy aspect of it. Is my screen visible?
Yes, ma'am.
Okay.
Yes, ma'am.
So a very good afternoon to all the participants. Thank you all for being there. And thank you, BCIP, again to organize such a wonderful thing. At the outset, I would like to say that this is very new for we physiotherapists because, of course, we see a lot of patients which come to us with knee pain and we work towards it. But this cartilage regeneration, though, is into orthopedics for maybe few decades now, but it's relatively still very, very new. So today I'm going to talk about physiotherapy management of cartilage regeneration. I believe Dr. Nishit will agree with me that now we even call it as interventional orthobiologics. So that itself is a newer branch where what all he has talked about, the interventions, what they do as orthopedic surgeons, physiotherapy plays a pivotal role. And the protocol, what we deliver, is clinically relevant to biophysical stimuli, that how much stress, how much compression one should put, or the amount of functional loading and other type of stimulation to facilitate healing. Our main purpose in this is, since the new graft is put, it should get healed and then working. So as talking about osteoarthritis, I thought I'll just put, as Dr. Nidhi mentioned, but at the same time, the prevalence of new osteoarthritis is around 23% globally. And to the surprise of people, it is more of younger people who gradually get into something like early osteoarthritis, where they found that the incidence, the ratio between male and male were more around 1.6%. Because most of them, they are again from their sports background, those who develop this. In Indian population, osteoarthritis prevalence is around 40%, where here it is more common in women. And 70% of the people, women with OA, they show radiological symptoms out of the total 45% of women which are involved into it. But what is the hallmark in that? That cartilage loss is seen in almost a lot of patients, and in end stage, by the time the cartilage loss is around 60%. If we talk of cartilage, I thought I'll just set the brief this thing that cartilage, we all know it's hypovascular. We all know it is this thing, it covers the whole area of the long bones, as you can see in the diagram, in all the diathrodial joints. And it is of three types: hyaline, which is more viscous, one can say, or more hydrous, elastic, and fibrocartilage. The function of cartilage is basically to allow low friction, pain-free, smooth joint motion, and also protects the joint against wear and wear by reducing the friction and the peaks of stress. As we all know about the biomechanics, we will get to know that where all are the stresses and how much. So this avascular or non-lymphatic nature or a neural nature of this cartilage, it predisposes to its degeneration, and there is a limited scope of self-repair or restoration. So generally, as I said, when we saw in the prevalence, it is mainly in sports injury or recreational injuries when the people come up with cartilage injuries. Along with the symptoms, what we see, it generally, when is not taken care of, it leads to osteoarthritis. And whenever in our practice we see menisci-like symptoms, but there is no radiological or clinical diagnosis what you can make on your assessment, then there should be a suspicion of chondral lesions. So if we talk of chondral lesion around the knee, then here I have put that what is the distribution of these chondral lesions. You would really, as we just talked in sports injuries, the causes are basically chronic repetitive microtrauma due to, and later maltracking may happen and other things. That is again all the biological, biomechanical factors which lead to chondral defect. And there can be trauma, acute injuries, patellar dislocations, which can also lead to these chondral lesions. And very much in the literature it is found that these people generally, they have associated, again, static structures are also involved. That is ACL and medial menisci tear are generally there. When we look of anatomical distribution, maximum times it is the medial femoral condyle which is involved. And patella, though, is less involved, which is around 17%. Trochlea and medial tibial protuberance is very less involved. The grading is done by various systems, which is something like International Cartilage Repair Society or Outer Bridge classification, which was given way back in 61. So though we as physiotherapists may not be much involved, but we should know most of the patients when they come to us, they are around grade 3. And I'll further interpret how it is. So here I just put it across for people to have little view on it, that when the cartilage is just normal, it is graded 0. And when it is, there is mild, what you can see, softening and swelling, which is grade 1. When it is partial thickness and it is not reaching the subchondral area, then it is grade 2. In grade 3, there is fissuring and it reaches the subchondral bone. And in grade 4, the whole bone is exposed. So what symptoms generally the patient come to us with? Maybe knee pain, stiffness, effusion. Post-injury, of course, we find patient coming with this. But yes, with the repetitive traumas also, they come up with the similar features, soft tissue swelling, some crepitus, giving way kind of feeling. As I said, it looks like menisci, loose body sensation, and functional limitations. So while examining as a physiotherapist, we must look at the malalignments, the range of motion, about effusion, instability, crepitus, as again maltracking of patella, whether it is laterally tracked or it is already in the beginning, it was alta or baja. So how do we really, a very important thing again would be something like monitoring the pain. Because for rehab, it is very, very important that we look that how much amount of discomfort or pain is there while giving the rehab. And various outcome measures are there, something like KOOS can be used, or Lechlom, which can be used to really find that what exactly is the pre and post-op recovery. Diagnosis generally is done by MRI, or even MRI cardiogram is used just to identify what is the exact nature and how big. And of course, arthroscopy is diagnostic as well as therapeutic. So purpose of cartilage regeneration is to restore ultimately healthy knee function. We saw how much of population is involved, and lately now these with the coming of orthobiological techniques, lot can be done. So what does happen when cartilage regeneration procedure is done? It basically includes preventive interventions and therapeutic solutions which can promote tissue regeneration and reduce cartilage degeneration, right? So techniques, as already Dr. Bhatnagar has spoken about. So I will not talk much about the techniques, but yes, to name them again, microfracturing, as we saw in his videos. And mainly I'm going to talk about the rehab in chondrocyte implantation or matrix associated chondrocyte implantation. He has already shown us very nicely that how autologous chondrocyte implantation is done. If we just look into the biomechanics, because all physiotherapists have very strong hold on biomechanics and they are taught very much. So very important to know about the applied clinical biomechanics, where we see that patellofemoral joints, normal functioning and stability is highly dependent on dynamic, which is all muscles, and static, which are all your ligaments, stabilizers. So here in this image, I've just shown that as you go into knee flexion, where all the patella on the femoral condyle has its contact. So more the degree of flexion, more is the patella contact. And with excessive knee flexion, it is just very little contact and the whole lateral condyle is almost, medial condyle is all free. So to support the healing by stimulating graft physiologically, in harmless positions, it's very, very important that we look for the lesion, the contact area. And for physiotherapy, especially, we should know that what is the contact area, how much the contact load should be there, what all should be the contact pressure for the healing to really come up. And this physiotherapy, as in the first slide I shown, that how really a physiotherapist can work towards physiological healing. But very importantly, one has to look into the lesion size, depth, and even the patient's age, BMI, and the kind of surgery which is done for physiotherapy. So ultimate goals of physiotherapy in this are that first of all, that local adaptation and remodeling of the repair, and then ultimately to return to function. The main components of the program are progressive weight bearing, restoration of range of motion, and enhancement of muscle control and strengthening. What is the major challenge to we physiotherapists is to optimize the achievement within an individualized and progressive framework. It's very, very important that the program has to be individualized. As I said, one has to look into the lesion type, size, shape, and how much time, the age of the patient, what is the BMI of the patient, and what exactly is done. Regenerative physiotherapy processes, it is into 3 phases. The major phase to begin with, where we are pretty guarded, is inflammatory phase. And here, pain control and guarded weight bearing is very, very important. Then comes the proliferation phase and the maturation phase. So during, it can be divided into 4 or even more phases, because here week on week one will find that there is progress, and as we go gradually, after the proliferation has set in, thereafter it may take even 1 year minimum to really get back to functional activity. So during proliferation phase, it is basically light exercises, and we gradually build up to range of motion. If I talk of matrix associated autologous chondrocyte implantation, then the management, I have just put it in 7 phases, which is immediate post-op, that is first week, to restore mobility, that is next 2 weeks, to strengthen and straighten is another 2 weeks, and then how one can get into independent movement, return to activity, and later on to recreational activities and return to full activity. So the stages of tissue development here are something like initially it is implanted and we require a protective phase. Thereafter, there is proliferation. Then comes the remodeling, and finally the maturation. So when we talk of it at immediate post-op, our major goal is to maintain joint mobility and muscle tone while adhering to all post-operative precautions, which I'll just talk about. And in this phase, as we say, we know biomechanics of the knee. If the thing is in patellofemoral joint, then it is little different. And if it is for the tibiofemoral joint, then it is different. As biomechanically we know, in full extension, the patella is not really loading onto the femur at all. So there, the things will be little different. So weight bearing to begin with is definitely less than 20%, which to the extent that how one can really measure it, that may be standing on a weighing scale with the crutches in the arms, under the arms, or this elbow crutches, and then stand on this thing, one leg, and see before that itself that how much is the load with two stick, and can you really put 20%. And at this time, the range of motion does not go beyond 20 degrees in patellofemoral and beyond 30 degrees in tibiofemoral defect correction. And this definitely protective knee bracing as a ROM brace is required. But a lot of literature which talks of, when we talk of tibiofemoral correction or regeneration, then it can be an offloader brace which can be used. And gradually, with 2 walking aids, crutches, one can progress. Certain contraindications, that excessive load bearing should not be more than 20%. It's very, very important. That is why I said that we should know VAS, and not more than 2 on 10 should be the VAS scale when you are giving exercises to the patients. Ambulation, of course, should not have to be even taken once without the aid, because our first goal is just to have that implanted regenerative cartilage material to be setting in. And there should be no generation of shear forces within the knee, so the brace is applied. So knee flexion beyond 30 degrees, as I said, should not be there in tibiofemoral and less than 20 in patellofemoral. And initially, there should be no active knee extension, especially against resistance. Otherwise, your operating surgeon has certain things, what he says that he has done it this way, or the defect was very little. Definitely, it is a very well multidisciplinary team approach where patient, surgeon, and the physiotherapist, they have to work together towards the progress and the success. So initial is pain control with analgesics. Initially, CPM can be given. In many studies, they talk of that CPM can be given even for more hours of the day regularly initially. And ROM brace has to be worn. As I said, that there should be no shear forces. Cryotherapy, of course, we all know the effects of cryotherapy 2 to 3 times a day. Ankle exercises and isometric contraction, because the limb is already in the brace, can be given. And breathing exercises, of course, we know the benefits of breathing exercise. What is very, very important, as I said, it is a multidisciplinary team approach when this kind of cartilage regeneration surgery is done. So patient and family education plays a very, very important role, where there should be a very good understanding given to the patient and his or her family, and regarding how the movement should be controlled for healing to begin with. So very important to tell that what ADLs one can do, one cannot do, what functional tasks one can do, one cannot do, and how safely one has to transfer in the bed, because this leg is in the brace itself. And the weight bearing status, as I said, it's very, very important to be informed to the patient and family. When we talk of phase 2, which is to restore mobility, here our goal is range of motion and flexibility exercises. Also still continuing with the CPM. And here we gradually progress to the more of weight bearing as well as more of knee flexion. So by and by in this phase, after 4 weeks, we are into this phase where we go on 30 to 90 degrees of range of motion in tibiofemoral and 30 to 60 degrees in patellofemoral. But rest of the things what we see, whenever the knee is braced, it is in full knee extension still. And the CPM is given passive, active heel slides, it started. And one is off the brace when you are doing the physiotherapy. Now we start with careful patellar mobilization. It's very, very important that patellar mobility has to be maintained throughout. So initially, it's very important from the very beginning, the patellar mobility is taught to the patient as well as physiotherapist regularly performs it in all the directions. Along with that, strengthening exercise of quadriceps, gluteal, hamstrings, adductor, calf, all is done. And straight leg raising in all 4 directions can be given. In phase 3, where strengthening and straightening is the main purpose, here the range of motion and flexibility exercises along with now stretches are also started. CPM is used as per comfort. Here the ranges what patient we target the patient should achieve. In tibiofemoral defect, it is 110 to 125, and active progress from 90 to 125 in patellofemoral. And protective knee bracing is of course used. In the beginning, as I said, it is definitely required, and thereafter gradually we wean off from that. And now the weight bearing is 40 to 60% in tibiofemoral joint, and it is almost full weight bearing in patellofemoral joint in phase 3. You again progress the straight leg raising activities. One can go into the dependent weight bearing status now. Sitting and standing, weighted hip abduction and adduction can be done. Along with that, trunk and strengthening exercises, having a good core, having good gluteus, because it is the whole thing which will work together, and working on the ankle is very, very important. So in this time, the recumbent cycling is also added. In phase 4, when we talk of independent movement, the goal is active knee range of motion within the anatomical limits, and pain-free 6-minute walk test is done without any assistive aid in independent movement phase. And here one can use the stationary bike without the knee brace. Independent exercises are told to patients that they can perform now, and now we emphasize on proprioceptive exercises. And gradually this phase ends with the progression to full weight bearing. In tibiofemoral, now again still 80% we begin with, and by 10th week we come to full weight bearing, or as stated by the orthopedic consultant. And in patellofemoral, it is full loading done by that time. Range of motion achieved is around 7 to 8 weeks. We find that the complete range of motion should be achieved. And protective knee bracing, of course, there is no brace now required after 2 months in patellofemoral, but there is protective knee bracing still used in the tibiofemoral joint. And gradually the ambulatory aids are weaned off. So when we talk of phase 4 here, ROM and flexibility exercise, like one can start with rowing ergometer, one can gradually start with the cycling, with a high sit cycle, and one needs to now introduce something like strengthening exercises with weights. That is CKC also, open chain, open kinematic chain exercises now. But before that, one is going for more of CKC, closed kinematic chain. Proprioceptive exercises make a lot of difference, which can be done in full weight bearing or even as in hydrotherapy pool. But gradual slow progress is done from partial to full weight bearing positions when we do it in hydrotherapy. As we all know, in hydrotherapy, buoyancy really acts and offloads the area and makes the movements way easier. But at the same time, when we do hydrotherapy, we can even act it as resistive exercises there. So proprioceptive exercise as changing postural position, changing the environment, proprioceptive input mechanism, that is with eyes open or eyes closed, the speed of movement, if is varied, the magnitude of the base of support, that one is standing on 2 legs or one is coming on 1 leg, and then reducing the base of support basically to see the stability, and introducing weight transfers or activity specific drills. As we say that most of the sports people are seen into it. So then going to their activity specific drills is a progression. Other therapeutic modalities which have been found to be effective is something like whole body vibration, which involves use of vibrating platform, which changes the amplitude when a patient can be taken in sitting or standing, any position, or even doing movements. These are small vibrations on which a platform on which a patient stands. And what it does, it just induces the reflex motor contractions, which may assist to improve muscle recruitment and proprioception. We all know when we even do wobble board, the proprioception really improves. Another thing which has been studied on this is blood flow restriction, which a tourniquet is applied to the extremity, you can say to the thigh, and then the exercises are given. With this restricted blood flow, it has been found that the limb girth really improves. Hydrotherapy, as I just spoke about, that hydrotherapy can be given in early mobilization, early loading, and of course to improve neuromuscular performance, coordination, and strength. Electrotherapy, yes, we do apply TENS, IFT. The recent literature does not talk much that whether TENS help or does not help, but yes, the literature talks of low intensity pulse therapeutic ultrasound and low level laser therapy in providing the appropriate stimuli for acceleration of chondrogenesis. So this is what I thought. Thank you, everyone, that I would share my views in it.
Thank you so much, ma'am. Diksha, there. Diksha, may you
Thank you
take the
so much,
question?
ma'am. Thank you so much, ma'am, for sharing your profound knowledge and clinical insight into the topic. Now we would like to take up the questions from our participants. And the first question is, will the surgeries be contraindicated in infectious joint conditions?
So I'll take that question. Any sort of infection or active infection in the joint is a definite contraindication for any regenerative sort of surgery, because that infection, the stem cell that you're going to put in is going to get eaten away by the infection itself. So you have to tackle the infection first, and then regeneration is something you can do at a later stage once the infection has subsided completely.
Thank you, sir. How soon can we start the physiotherapeutic rehabilitation after the surgery?
Shall I take this?
Dr.
Of
Seema?
course. Yeah. It is definitely, as I have put in my slide also, it is like a multidisciplinary team, and from the very beginning one can go. So even literature talks of prehab also in this. Though this is very new technique which is being done. So when the patient comes to you even prior and you work on the other joints across, right? So you can give, maybe you can work on glute better, you can work on their other muscles better. So the once this is being uptake, or in the first phase, yes, we are guarded. As I said, that one has to look into VAS, that what is the pain, and of course in conversation with consultant, that what he really feels and what exactly is the procedure. According to that only one has to go for the rehab. But there's a lot literature. Initially it was putting into immobilization, but lot of literature it talks of that immobilization does not help. It has to be, of course, with the ROM brace, with very much guarded, you can say, loading, very much guarded. As I in fact mentioned, that one, how one can really learn that doing less than 20% or just a toe touch, right? But again, putting it that way. And of course, as what I believe Dr. Nishit can further take it up and let us know more on it.
Ma'am, I would completely agree with your point about prehab, because that is something which is, maybe we do not focus on it that much because we are in the process of getting the patient ready for surgery. But in the few patients that we have had a chance to do even a little bit of prehab on explaining how they will have to walk and what sort of exercises they will have to do after the surgery, they are much more receptive before the surgery when they are pain free. Once their mind is occupied with the post-operative pain, then teaching them those same things become very difficult. So prehab is definitely something which we should be focusing on much more, not just in cartilage regeneration, but even in other surgeries like arthroplasties or ligament reconstructions.
Thank you, sir. The next question is, how successful are the cartilage regeneration surgeries, and does it has to be repeated in some cases?
So these techniques are still relatively, so some of the techniques are well established, like drilling and mosaic plasty and oats, but like autologous chondrocyte implantation, etc., are still in their developmental stages. We still do not know what the best way to fix the stem cells onto the subchondral bone is. So the success of surgery is quite variable. And if the patient selection is good, then of course they tend to give good results. But if the patient selection is poor, then no matter how good the surgery is, the result is not going to be as good as the surgeon or the physiotherapist would have wanted. So it is still in the developmental stage, I would say. And the demands of the patient and the expectations of the patient have to be taken into account. If the patient is expecting to return to sports at a very high competitive level, that might not be the best indicator of success.
Thank you, sir. Next question is there any grading or criteria to decide the surgical management?
So that's a very good question. Since these surgeries are relatively new and these procedures are relatively new, there is not a very well fixed or established protocol of what surgery to do in which case. It has to be individualized to each particular patient. But there are 4 basic points that you need to look at to decide what surgery is to be offered to which patient. 2 of those points are related to the patient, and 2 of those points are related to the cartilage defect. So the age of the patient and the demand of the patient. If the patient is young, pre-adolescent or adolescent, then they have very good regenerative potential, and reparative techniques like a drilling or a retroarticular drilling will provide very good results in them. But if the patient has crossed into young adulthood or even middle age, then you cannot, then the reparative techniques are of limited value, and you have to do something which is restorative or reconstructive, like a oats or a mosaic plasty. And as age goes on further, then even those procedures become not well suited, and you have to think of palliative procedures or a replacement of the joint. Similarly, you have to look at the demands of the patient. If the patient has a very high demand athletic individual, then you are trying to give him a good hyaline cartilage back, and that's why you need to do a reconstructive or sort of procedure. And as Dr. Seema had also touched upon this type of lesion, so she had mentioned the outer bridge classification and ICRS classification. So you have to take into account what the stage of the disease is. A early stage 2 or 3 disease, you might get away with a drilling or a mosaic plasty, but in a stage where the subchondral bone has already been exposed, you probably need to do something to implant stem cells or cartilage into that. So the size of the lesion, if the lesion is very small, you can get away with an arthroscopic osteochondral transfer. But if the lesion is bigger, you have to do a mosaic plasty because you need multiple bone plugs, which you cannot do in an arthroscopic manner.
Thank you, sir. Next question is there any contraindication of weight bearing post-operatively? Dr. Seema?
Weight bearing, of course, I believe I mentioned from the very beginning, it's very, very important aspect because initially it is the protection phase only. So contraindication, of course, is there that you have to be going by definitely because there are compressive forces which will not allow the protection, the healing to happen. So it's really, really important that how much load should be given in the beginning. Most of the times, people are told just to use CPM and maybe do bed activities to begin with. To that extent, that there is no loading to begin with. But lately, it has been told that limited loading works good. So because these loading and shear forces, they can gradually enhance the regeneration also if done judiciously.
Thank you, ma'am. The next question is, at which week should we go for agility drills and plyometrics?
I believe Dr. Nishit will agree with me if it is people who are into their sports because rest of the body is fairly good, their rest of the musculature is fairly developed. So maybe around 16 weeks onwards to 26 weeks, they are into very, very light stuff and thereafter they can really go into it, the soft games. Do you agree to that, Dr. Nishit?
Yes, ma'am. Eventually, the aim should be to return to light sports by around 6 months and maybe competitive contact sports by 8 to 9 months. To reach that age, to reach that stage, you need to start these agility drills, turning and pivoting movements by maybe 4 to 5 months, which is what you mentioned.
Thank you, sir. Thank you, ma'am. There is a question in the chat box. Ma'am, I have undergone ACL on 7th December. Right now, I am walking with a walker. Can I start weight bearing at this stage?
I believe in this, what is to be known as I had really made the chart where whether what defect is it, what defect has been corrected. So would be everything relative to that. What you have to say, Dr. Nishit, on that?
Ma'am, we really have very limited information just undergoing a
Yes.
ACL reconstruction on
Yes.
17th. If it's
Sir,
straightforward
It's
ACL,
ACI. I believe it's ACI.
ACI. Oh,
But
sorry.
again, whether it is patellofemoral, whether it is tibiofemoral, then how much loading should be there? I believe you agree that that would be a thing to do.
Yeah, we need to know whether it's a patellofemoral or tibiofemoral, what area, whether it was a weight-bearing
Yes.
area or a non-weight-bearing
Yes.
area.
Yes.
That really is a very critical
Yes.
point.
Yes.
The participant is saying that patellar lesion was there.
Okay, so has the what is the rehab protocol being told to that patient? Patient has to first be, I mean, we need to know that what protocol has been told to the patient, right? So
Thank you, ma'am. And the
I mean,
next
might be
question
doing
is,
CPM and stuff, might be doing that patellar mobility. I believe it should be little of use what I have put across in the rehab. Because it is just 3 weeks, 2 weeks.
Okay, ma'am. The next question is, if a person who is not athlete and having severe ACL tear, her calf muscle is also going under wasting, then what can be done for her? She is 23 years old.
She should meet rehab team, the whole. That should be the answer, because it can't be really told that what should be done now. She has to be meeting one therapist and an orthopedician, and maybe can look, because I believe Dr. Nishit would agree with me that many of the patients which I just touched upon, that those who have chondral defects, along with that, they are found to have these static structures also involved. So if
Yes.
ACL is involved and that is there, which or whatever this acute trauma has come, so maybe he would be on this point getting all the investigations done and really finding that whether he would like to do the static structure first and thereafter would be going for this defect, what has come up. So I believe you can take up this question better than me.
I think this particular case is maybe a good case for prehab, that she can undergo some good calf strengthening, because ACL is not since she's not an athlete, ACL is not a very emergent or urgent surgery for her. She can develop her calf muscles, quadriceps and hamstring, and then subsequently go for a ACL reconstruction, which will also lead to much better results.
But even this leading to more of cartilage defect if left
Yes, so
untreated.
we should be, as you said, we should be taking care of the ligamentous lesion first, and then taking care of the cartilage defect. Maybe in the same sitting, if it's a small lesion, we often do a mosaicplasty along with the ACL reconstruction, or maybe in a second stage.
And definitely a good physiotherapy before that.
Thank you, sir. Thank you, ma'am. The last question for today is, how can we teach patellar mobility to the patients?
I believe as physiotherapists, we all have been taught, right? We can definitely go and teach them. I believe in practice, many of you might be, many means all of you might be doing it. Do we do it? I don't know. I mean, it's basically that you just tell the patient how to really move the patella with both hands. You can see, and then we go. Yeah. And those who have done McConnell's courses, they would be definitely knowing that patella plays such an important role. So otherwise, if we are not talking of regeneration, we know that mobilizing the patella can really help into a lot of our defects, isn't it? That when we talk of chondromalacia patellae, taping and everything is there, and how do we really test them? We mobilize the patella and really test when we talk of McConnell testing for chondromalacia patellae. How we are going to do? We are going to mobilize the patella and see, are we pain-free in that isometric range? If we are pain-free, only then we say that yes, it is something of that kind of defect where we are going to work. So it is with your hand and fingers, you can always mobilize the patella.
Thank you, ma'am. Thank you, sir. Thank you, ma'am, for sharing, for clearing our doubts with such depth and yet simplicity. Thank you so much. Today's webinar was indeed a great learning experience to enhance our zeal and expertise, as well as add to our skill set. Now, I would like to invite Dr. Shaheen to give the vote of thanks.
Thank you, Diksha. On behalf of the entire fraternity of BCIP, I would like to thank each and everyone present in this webinar. I would like to extend a hearty thank you to Dr. Nishit Bhatnagar for accepting the invitation. I would like to thank you, sir, for motivating us that we can take any big endeavors at such a young age. Thank you so much for sharing your personal surgical experiences, and that too the newest and the most recent surgical approaches in the field of orthopedics. Thank you so much, sir. I would also like to thank Dr. Seema Grover for taking out time for us from her busy, very busy schedule. We could hear a phone call also in between. And personally, I know ma'am, so I would like to say that she is one of the senior most clinicians, physiotherapist clinicians in the country, but she has a heart of a very young intern who has just the zeal of learning, and she can find the aspects and prospects of physiotherapy in any possible medical condition and surgical condition. Thank you so much, ma'am, for always motivating us to always think of the aspects and prospects of physiotherapy. I would also like to thank all the participants and the faculties from all over across India and abroad. I would like to thank all my internal students, all the hosts, the literary and the social media club students for hosting this webinar. And also, I would like to thank my colleagues and the management for providing me this opportunity to host this webinar. Thank you all so much. This video would be available on YouTube. So you can find it on YouTube on the channel BCIP, Binarsidas Chandiwala Institute of Physiotherapy. And also you can find the link on various social media platforms like Twitter, LinkedIn, Facebook, Instagram. So this would be available. Please don't forget to like, share, subscribe to our channel to motivate our students who are always trying to have this learning and teaching experience. Thank you so much, everyone. Thank you. Have a nice day. Don't forget to fill the feedback forms.
Thank you, Dr. Nidhi.
That will motivate us and make us learn like where's the lacking point.
But I would like to congratulate BCIP for specially choosing this topic, which is very new. And I believe it will be a great learning experience for people to really know about it and work towards it.
Thank you so much, ma'am. That was Dr. Nishit's call.
And I would also like to thank the organizers for this wonderful session. And I would like to say what my seniors and my professors used to tell me, that the difference between an average orthopedic surgeon and an excellent orthopedic surgeon is the post-operative physiotherapy. So we are very much indebted to all of you to help us provide the good results, even if we might not do our best job.
Thank you so much, sir.
Thank you.
Thank you so much.
Thank you. Bye.
Thank you, ma'am.
Thanks. Bye.
Bye, ma'am.